Hi everyone, today let's look at ECG. ECG is one of the tests used in diagnosis of cardiac problems. One of the cardiac problems that we can diagnose using an ECG is what we refer to as myocardial infarction, cardiac arrhythmias, hyperkalemia, fibrillation, tachycardia, and bradycardia. We have a few terms here to define, but before that, we need to know that your body is a good conductor of electricity. Why? Because it has fluids. It has fluids, and these fluids have ions. They have ions. So movement, when you subject your body to an electrical circuit, it will conduct electricity because it has fluids and ions. And for example, if I have a cell here, a human cell, then I have extracellular space here. Let me just make it that way. Maybe just let's assume we are using one cell right there. So this one is intracellular space, and this one is extracellular space. So if I put an electrolyte here and then an electrolyte here across this cell membrane and connect a voltmeter here, I will be able to read some charge. I'll be able to read some voltage inside here, meaning there is an electrical charge that exists between extracellular space and intracellular space across a cell membrane. And this charge that exists between these two, for example, if it is negative 60 millivolts, then this is what we call resting potential. That is resting membrane potential. Resting membrane potential. So if you connect an electrolyte on your cell and extracellular space across a cell membrane, you'll be able to read some charges right there. And that is what we call resting membrane potential. Different cells have got different resting membrane potential. The normal cells, majority of them, they normally have a resting membrane potential of negative 60 millivolts. And then a nerve cell usually has around negative 70, while a muscle cell usually has about negative 90. So this is a resting membrane potential, which is a normal polarized state of the cell. It can be negative 60 millivolts, negative 70 or negative 90 is a negative here. So when the cell has this charge, we say this cell is polarized. That is why we are defining it as a difference in electrical charge across a cell membrane. And therefore, the inside of this cell is negative. That is negative intracellular state, which is relative to the extracellular space, which means this cell inside here, the intracellular space of this cell, if I can draw it even much better, like this, means inside this cell is more negative. It's more negative compared to extracellular space, which is more positive. So this cell is in what we call a polarized state. So that is the meaning of polarization. So next, Next term is depolarization. Depolarization. So I want to draw a graph here to illustrate the meaning of depolarization. If I plot a graph here of, let's say, voltage against time, and then I have my cell here, which is at negative 60. Let me just make it look well. So this is our graph, and we are plotting voltage of our cell against time, and our cell is here with negative 60 millivolts there. So meaning when you go upside, you are moving towards positives, that scale. And when you move down on this scale, you are moving towards more negatives. So if let's say maybe you have 50, negative 50 here, then negative 40, negative 30, all the way to zero, and then all the way to positives up there. And down here you are going more negative, maybe 70, maybe 80 downwards as you proceed. If I change this charge towards positive, that is depolarization. I will be depolarizing this cell, which means I am moving it from the negative state towards the positive state. So that is depolarization. So this will be depolarization. So when you change the resting membrane potential of a cell from negative towards more positive, that is depolarization. And repolarization is the opposite of depolarization, which means if I was at the positive state and I come back to my original negative 60, then I have repolarized that cell. That is why we are saying the membrane potential is returning back to its resting potential after depolarization. And what is hyperpolarization? Hyperpolarization is now when you move from the resting potential farther to more negative. Because if it was, this cell has a resting membrane potential of negative 60, then I go to negative 70, I have hyperpolarized that cell. So that's why we're saying that this is the membrane potential which becomes more negative than the resting potential. So there's something called a lead. This is just a view. Or the anchor of the heart's electrical activity, which is created by comparing the signals from two or more electrodes. There are 12 leads on an ECG, and that is 1, 2, 3, AVR. This means augmented vector. It can be vector, sometimes they call it a voltage of the right arm. So it's an abbreviation. We shall see in the subsequent slides. So there are 12 leads on an ECG. We shall see what it means as we proceed. Then what is an electrode? An electrode is a sensor. It is placed on the body to detect the heart's electrical activity. Remember we said our body is a good conductor. It's a good conductor of electricity. It's a good conductor. So if it's a good conductor, it means if I connect electrodes on the surface of your body from negative electrode to a positive electrode to a negative electrode with my voltmeter around there, I'll be able to pick some charges. So electrodes are just sensors which are placed on the body to pick electrical activities. And there are 10 of them. We have 4 for the limb and we have 6 precordial ones. Those precordial ones are also known as chest electrodes. We shall see as we proceed. This is what we have been talking about electrical potential, resting membrane potential. So this is our voltmeter around there. When you connect this voltmeter, if I take one electrode here, this one here, and another one here, so we are saying this is extracellular matrix outside the cell. This is the cell membrane. What you are seeing here, the whole of this is the cell membrane. Inside here is the intracellular space here. So if I have an electrode connected here and another one collected in this space across this membrane, then you are able to pick some charge, and that is what we call the resting membrane potential. So that is an illustration of what we have already explained. This is the heart. Just a review of the cardiovascular system. The function of the heart is actually a pump. Heart is just a pump. And this pump, its function is to pump blood across all systems. And this one has been doing that job all the way from when you are born up to now. When it stops, it becomes issues. Therefore, it means this heart is a very important organ in the system, because if it stops, then it means you will not be able to supply blood across the body. So this is just an illustration. So there's the heart here. Then we have 2 sets of circulatory system, pulmonary circuit and systemic circuit. So that's just to show the function of the heart. The heart has 2 mechanisms of function. We have electrical activity, which is normally tested or checked using an ECG. We also have mechanical activity. This one is usually checked using an echo. But remember, electrical activity is the one that leads to mechanical activity. So if electrical activity fails, then the mechanical activity definitely will not work. And mechanical activity is all about contraction and relaxing. That is when it is pumping blood. So for us to initiate the mechanical activity of pumping and relaxing, pumping the blood, we need to start with the electrical activity. So it is the electrical activity that stimulates the mechanical activity. We have characteristics of heart muscles. Atomicity. It means there's some sort of automatic, from the word automatic. So these muscle cells are automatic. They also have rhythm. They can conduct electricity in a rhythmic state. These cells are also excitable. They can also conduct electricity, and they can contract. This is the special characteristics of heart muscle cells in relation to its functions. So this is the excitation conduction system. So our electrical system starts from this point here. This is what we call the SA node, sinoatrial node. Sinoatrial node. So it's also known as the pacemaker. Pacemaker. Also known as the pacemaker. So automatically the electrical potential originates at this point. Then it is pumped towards the left atrium. This is the left atrium here, left atrium. This is the right atrium. This is the right ventricle. This is the left ventricle. So our electrical signals will originate at the SA node. Then it will go to the left atrium. Then other signals will come to this point, what we call the AV node, atrial ventricular node. This one here. Then from there, it will come into this bundle here. It will come into this bundle, which now comes down and splits into two, whereby we have the left bundle of His, and then we have another right bundle of His. Then this charge will come up to this ventricle and also to the left ventricle through the Purkinje fibers. Purkinje fibers. So these are the fibers that now will become polarized, depolarized, and then initiate muscle contraction of the heart. So how does these signals flow? How does the electrical charges flow in the heart? We have said it will start from the SA node, then it will go to the atria, then to the AV node. It will delay a little bit here. It will allow the ventricles to fill blood fast. That is why there is a delay. Then from there we go into a bundle of His, which can be right and left. So it divides. And then finally you have a ventricular contraction. So what is ECG? Let's look at the definition. It is an electrocardiogram, and it's used to record electrical activity of the heart over time. And it's usually captured by electrodes, these ones here, on the skin. It therefore reflects the atrial and ventricular depolarization. Remember, we defined what depolarization means. So an ECG just records electrical activity of the heart through electrodes which are connected on the skin. Some of the things that an ECG can pick is the heart rate. It can also pick the heart rhythm and electrical conduction as well. What are the symptoms that we use or we look at before we send a patient for an ECG? We look at these symptoms: chest pain, dizziness, palpitations, shortness of breath, fatigue, sometimes fainting. So some of these symptoms are indications for an ECG. An ECG looks like this. This is the machine itself. So that is how an ECG looks like. And this is the procedure. This is the procedure of how to do an ECG. So the patient is placed on the bed, and then the electrodes are connected. What you are seeing here are the electrodes. And these electrodes are precordial. They are precordial or chest. Remember, we said we have 6 precordial electrodes and 4 limb electrodes. So the patient is positioned that way, and the electrodes are placed in that order. So how do we place the precordial electrodes? You look at the sternum, assuming this is our sternum around here. Let's use this as our sternum bone with that angle there. So you locate this suprasternal angle. it correlates with intercostal space 2. So down here will be intercostal space 3, and then down there will be intercostal space 4. So on the left and also around here. So what you simply do, you place your electrode. These electrodes, precordial electrodes, are labeled as V1, V2, V3, V4, V5, V6. So you will place your V1 here, V1, and then V2 here. From there, then you go to V4 is usually you locate the clavicle, and then the mid clavicle, an imaginary line, the mid clavicle, in the fifth intercostal space, fifth here. So you place your V4 here, and then in between V2 and V4 you place your V3. And then when it comes to V6, you look at the mid axillary line, mid axillary line, which is imaginary. If it is there, then you place your V6 here, and then in between V4 and V6 you place your V5 there. So that is how we arrange. That's how we arrange the precordial electrodes. The limb electrodes are 4. They are 4 in number, and they are color coded. So we have red, then we have yellow, then we have black, then we have green. So this one goes to the right arm, while this one goes to the left arm. This one will go to the right leg, and then this one to the left leg. So they are coded. So you just place on the limbs with that color. They are coded. So this is how a normal ECG looks like. It's an ECG sample. It looks like this. When you look through, you'll find that there are 4 rows. 1, 2, 3, 4. The ECG report has 4 rows of waves. So we have the first row, the second row, the third row, and the fourth row. And when you look at these rows, each row has 4 leads. There is, for example, if we look at this, there is a lead here, from this point to here, from here to here. There is a lead, that is lead 1. Then from this point here to here, we have AVR, that is augmented vector right, which is also another lead. Then from here to here, we have V1. Then from here to here, we have V4. So one row has 4 leads. And we say an ECG has a total of 12 leads. 12 leads, which means if I have 4 here, 4 here, and 4 here, then that is 12. This one is just a replica of V2, and it is continuous. So it's not among these that we use to calculate the total number of leads. This one is usually used when you want to look at the heart rate. So you use it to calculate the heart rate and even to check arrhythmias. This one here. So every row has 4 leads, and these leads are different, and each lead, we said from the definitions, it checks. These leads, they check the heart, they check the electrical activity of the heart in different angles. We shall see. So, for example, lead one, if you draw your heart, assuming your heart looks like this, then your lead one will be here, which will be picking the signals of the heart on this side of your heart. If you connect another lead here, then it will be picking this side, this side. That is the lateral side. So different leads pick electrical activity of the heart from different angles. We shall see. We shall see which lead picks signals from where, and so on and so on. But the most important issue here is to know that an ECG report will have 4 rows, of which the first 3 rows have four leads in each row, while the last row is just a replica of V2, and its function is to check or to calculate the heart rate. We shall see as we proceed. So this is how the patient is placed when you are taking the ECG recording. So these are the electrodes we have been talking about, and these ones are the chest or precordial electrodes. So that is how they are arranged. Now this triangle here is called Entovens triangle. Remember, there is a Dutch physiologist. Dutch is just nowadays known as Netherlands. This is a country. So there is a physiologist from this country called Netherlands, who is called Willem Einthoven. This guy here is the father of ECG. He is the father of ECG. He is the guy who discovered the concept of ECG in the year 1903. This guy here. That is why this triangle was named after him. So it's called Einthoven's triangle. He's a physiologist from Dutch, that is Netherlands. So he's the guy who discovered the issue of ECG. So let's see, what is this triangle talking about? This triangle is demonstrating the limb leads. Limb leads. When you connect an electrode from the left arm to the right arm, this one will give you lead 1. And lead 1, it picks signals on the superior surface of the heart. Lead 1. If you connect another electrode from here to here, it will give you lead 2. So, if I may redraw that triangle here, just use another pen. Then we are saying this is the left. Sorry, this is left. This is left arm, and this is the right arm. And this one here is the left leg. So, electrical charge that is picked from this point to this point gives us lead 1. Then the electrical charge that is picked from this point to this point will give us lead 2. Lead 2. Then the electrical charge that is picked from this point to this point will give us lead 3. Lead 3. So if our heart was somewhere here, let's say that is our heart, then it means lead 1 is picking electrical charges of this area of the heart, while lead 2 is picking electrical charges of this surface of the heart, while lead 3 is picking signals towards this other side. So that is what it means with the lead 1, lead 2, and lead 3. And then you can realize that in between, we have what we call augmented leads. Augmented leads means, for example, if you look inside there, there's a lead that's coming from this point, and this point, of which this one is AVR, and the other one is AVL, while this one is AVF. So, for example, if we want to connect, when we want to get AVL, remember we said this is just S means augmented vector, left. And this one means augmented vector right, while this one means augmented vector foot, because this is the left leg here. So how do we get these leads? You get a positive lead from that point, then you get the average. These ones are usually calculated by the ECG. These three, that is the AVL, AVR, and AVF. These ones are usually calculated by the ECG machine. So how does it calculate it? It takes, for example, the AVL. It will take the charge between these 2 points and get an average. Use that average to connect with this to give you an AVL. And if you want to get AVR, you get an average of this with this, make it your electrode here, then you connect to this. So this will be positive plus a calculated negative here to give you AVR. And how do we get AVF? This one, you get the average of this, and then get it here. So it becomes your negative electrode. So from this, you connect to this, then you get your AVF. That's why these ones are normally known as augmented. They are not physically identical. They are calculated by the machine. So this is the work. This is the work of these physiologists. So from here you can see we have already 6 leads. We have lead 1, lead 2, and lead 3. That is L1. Let me just wrap here again. So already here we have 6 leads. That is lead 1, lead 2, lead 3. Then we have the augmented ones, which is the AVR, AVF, and AVL. So this is 1, 2, 3, 4, 5, 6. 6 leads already. So that is how we get the six precordial leads, and they are demonstrated. As you can see on this diagram here. So our lead 1 is here. Our lead 1 is here, connecting between the right arm and the left arm. Then our lead 3 is here, connecting between right arm and left foot, and so on and so forth. So this is how we get our first 6 leads. That is how we get our first 6 leads using the four limb electrodes. This one here. Now, how do we get another 6? We need now to get another 6 leads using chest or precordial lead electrodes, because remember we said ECG has a total of 12 leads, a total of 12 leads. So we have already seen our first 6 using the limb electrodes. Now how do we get the another 6 using the chest electrodes? Remember we said our chest electrodes are 6 and they are named V1, V2, V3, V4, V5, V6. So what normally happens is that when you have this triangle here, the Enthoven's triangle with the standard, with the left arm, then there's the left leg. Standard limb electrodes, you get the average of this, and this, then you get our electrode here, which is now a negative one. So that's the first step. The first step, an average of these 3 gives us a reference point here. Now it's connected to the positive one here. So this one gives you another lead. This one will also be connected here to give you another lead. This one connected here to give you another lead, to give you another lead, to give you another lead, to give you another lead. So this lead is what just takes the names or the labeling of these electrodes. So this lead is just V1, and then this lead is just V2. This one is V3, V4, V5, V6. So that is how we get our 6 leads. That's how we get our 6 leads using the precordial electrodes. And you can see it is demonstrated there. So the previous 6 plus this 6 gives us 12. That's why we say the ECG has 12 leads. So, and remember, each lead also checks different angles of the heart. So when you are interpreting an ECG, you must have an idea of this. You must know, if I'm looking at this lead here, which is labeled LV1, or sometimes it's just labeled as V1, that graph. So it means you can have an abnormality here but not here. So let's say if there is a abnormality of QRS complex. So if there's an abnormality in this wave in V1, then you have to know that which part of the heart is affected, because you can have an abnormality in one of the waves in one lead while the others are normal. That is why it's important to know each lead, where does it check. We shall see as we progress. And that is the next slide. That is what it is demonstrating. What normally happens is that we have inferior leads. That is the bottom. Here, the lead that looks at the inferior. If you have your heart like this structure here, and so this will be your inferior. This is inferior, while this is superior. This area will be superior. This will be lateral. You have lateral towards outside. Outside, this is lateral. And maybe this is medial. But sometimes in relation to heart, we just use lateral. So it is lateral right or lateral left, depending. So inferior leads, we have lead 1, we have lead 2, lead 3, and then we have augmented vector foot, augmented AVF. So these 3 checks the inferior side of the heart. Therefore, if you have an abnormality in any of these, then it means the region of the heart that is affected is actually inferior. Laterals, we have lead 1, AVC, AVL. We have lead 1, we have AVL, we have V5, V6. So these leads, they look at the lateral wall of the left ventricle. So this is the left ventricle, and this is the right ventricle. So we have lateral side of the right ventricle. We have also lateral side of the left ventricle. So if you have an abnormality in any of these waves, then the region of the heart that is having the problem is the left lateral side of the left ventricle. Then in anterior just in front. So anterior, when you have a sagittal plane, for example, a sagittal plane, I don't know how to demonstrate this, but anterior just in front. So we have anterior. So if we have something here like this, and let's say this is facing this side, then this is the anterior, while this is the posterior. So if your heart is somewhere here, let's say somewhere here, then this side is the anterior, while this side is the posterior. So the leads that check the anterior aspect of the heart, we have V3 and V4. So those ones they check the anterior aspect of the heart. So if there is an abnormality in these two, this is V3 and V4, then the anterior aspect of your heart is the one that has a problem. We want to look at the types of ECG waves, and there are 4. We have the P wave, this one represents the atrial depolarization. While the QRS complex, these ones represents ventricular depolarization. The T wave, this one represents ventricular repolarization. While the ST segment, this one it's not a wave, just a segment between the S and T. That is after repolarization of the ventricle and repolarization. It's just a segment between S and T. We shall see as we proceed. So those are the four waves. So this diagram shows us this is the P wave here. P wave is here. Then this is Q here, R, then S. So what normally happens, if I may draw here just to demonstrate these waves, this is our wave. This is a P wave, P wave. Then from here, this is a straight line. There's another wave here, which we normally call it Q. Then from there, if this line is continuing like this, then we shall have another one here, which we normally call S. Then on top of this, we have another one that comes like that. Then this is what we call R. So this one is R, this one is Q, this one is S. When they combine, when we combine them, the three, that is when we get what we call the Q, the QRS complex. QRS complex. So from here now, you get a flat here, and then you get your T wave here. This one is T wave. This one usually indicates ventricular repolarization. Ventricular repolarization. That is when the cells, the state is returning to normal resting potential after depolarization, as we defined earlier. So this is just how those waves looks like. This is our P wave, this is the QRS complex, and this is the T wave. And we said the P wave, this one, is for atrial depolarization. So if you have abnormality in the P wave, it means the part of the heart that is affected is the atrium. Remember the heart itself, if we use this sketch, has 4 chambers. This is the atriums. These up ones here are the atriums. While these are here, these are the ventricles. So we can have a right atrium and a left atrium, a right ventricle and a left ventricle. So if you have a problem in your P waves, and we are saying that the P waves actually represent the atrial depolarization, if you have an abnormality here, then it means your heart in the atriums, that is where the problem is. And if you have a problem in the QRS, because QRS represents ventricular depolarization. So if you have a problem in the QRS wave, this one here, QRS, there's an S here, then it means the ventricles have a problem. The T wave, we said it represents ventricular repolarization. The T wave. So this is a continuation to explain what we have already talked about. The P wave for atrial depolarization, QRS for ventricular depolarization. There's usually also an atrial depolarization, but it's not picked on the ECG waves because it's usually masked by the QRS waves. Then you have the T wave, which actually means ventricular repolarization. Then you have what we call the PR interval. PR interval. The PR interval is the period between a P wave deflection and QRS. So P wave to QRS. That is what we call the PR interval. The PR interval. The normal duration is 0.12 to 0.20 seconds. And this PR interval reflects whether an impulse conduction from the atrium to the ventricle is normal. Remember, this one is for atrial depolarization. While this one here is for ventricle depolarization. So from P to QRS, that is from the completion of atrial depolarization to ventricular depolarization, that period is PR interval. It's what we call the PR interval. And the normal time that it should be taken during this interval is 0.12 to 0.20. So anything beyond this, anything beyond 0.20, it means there's a problem in conduction between the atrium, so between the atriums here and the ventricles here. When there is a delay, anything beyond 0.20, that is what it means. The RR interval is the time which has elapsed between the successful R waves. I want to demonstrate what an RR looks like. So if this is our wave, this is our P, and then this is our QR, then this is our T, then this is, you proceed, then this is our P again, and then this is our Q again. As you continue like that, this is Q, this is R, this is S,